Charlie Wahl here. We're going to be talking about dentures today and really focusing on, um, digital, of course, but applying the analog concepts to really kind of fine tune and understand what we're doing in the digital world, where teeth belong, where they fit in the mouth. All of those things are critical to having dentures that actually look like teeth and not just, you know, those typical old school dentures that most people tend to walk around with. So, um, one of Dr. Dawson's, one of my favorite quotes of his, as the years went through was, talking about digital dentistry. And, he, and this was probably in 2016, 2015, somewhere around there, he said digital dentistry is definitely the future, but in the absence of sound occlusal principles, it's only going to allow us to screw things up faster. And I feel that's the same when we talk about digital dentures, in that, without sound principles of removable, it's only going to allow us to do the same thing. And so I think it's crucial that we really focus on all of the things that we've learned through the years, whether in school, in private practice, and extra, additional training that helps us to apply all of the things we know we should apply and use it in a more efficient manner. And, my goal every time I implement something new is to try to figure out how can I improve, enhance, or replace what I'm already doing. And I think with digital dentures, we're at that point. And so no matter whether we use analog or whether we look at digital, the the six removable prosthodontic principles all apply. Condylar position, we have to know what the jaw relationship is. We have to have a good occlusal plane, the understanding of where teeth go, where they fit in the mouth, in the smile. Vertical dimension is crucial. And then, of course, aesthetics and phonetics. We don't want to do things that don't look good. We need them to function well, and we need people to speak properly. And if you look at these six principles, they kind of apply to all of our dentate patients well, right? All the things we learned at the Dawson Academy. We follow all these things through our checklist every day as we work through our treatment planning. And so looking at these six cases, there's a lot going on. There's failing fixed, there's failing removable, there's implants that need teeth, there's dentate patients that have, decayed terminal dentition, all kinds of things. Well, how do we figure out where teeth go? The easiest solution when we have large amounts of spaces is some type of removable. And, all six of these cases, not every single one finished in a removable prosthetic, but the best way to establish tooth position in large open edentulous areas, as I said, is using a denture. And so on all these cases, transitioning and going through the planning with some type of removable allowed us to be able to figure out where things belong, which ultimately provides better, more predictable outcomes, which is always our goal. And as we said, talking about digital, why should we change what we already do? And I think all of us, especially early in our careers, dentures were kind of put to the backside. We wanted to do them, but we struggled with them. And as we matured through our practice, we, either made that decision, I love dentures, which was a small percent of the population, or hey, if there's anything I can do to not have to do dentures again, I'm all for it. And understandable, because the way we learned them was tedious. The way we learned them included a lot of different steps that, required just effort and time. And almost always, because we weren't reimbursed well for this procedure, we kind of were like, should I really be doing this? And we didn't spend enough time. And I think out of all the things we do in dentistry, the key to our success is when we invest the time to learn and really understand what we're trying to achieve, and as we always talk about, understanding the end point before we begin. And so digital provides a lot of factors. The fit is better. These materials are very strong. We can definitely save chair time. We have lots of materials that we can use. One of the key things I love about this is we can control the thickness of the prosthetic. The software will generate a minimum thickness of any measurement that we want. And so strength comes in uniformity. And so to be able to design a prosthetic instead of melting wax to determine thickness, we can tell the software to hey, I want that at 2.5 millimeters. I want it at 3 millimeters. I want it at 2 millimeters, and it'll uniformly give us those measurements. The other nice thing at digital is we do a try-in, we can alter the setup very easily. If you think about, we try in a denture traditionally in the analog world, and we kind of hesitantly give a patient a mirror because we want them to spend about 5 seconds critiquing it, and hopefully they like it. And if there's something that needs to be changed, we're pretty much committing to having the lab reset almost, the whole arch of teeth. Even to move a midline just 1 millimeter requires moving all of those teeth. Well, in digital, we'll show that we can easily manipulate tooth position, occlusal plane, and do lots of things with a click of a button. The ability to have these files stored. So, as our patients get older, transition into extended care facilities, you hear lots of stories of dentures getting lost, misplaced. The ability to refabricate with the print, push of a button is very important for our older patients. And then also, just an improved workflow, which we're really going to focus on in the digital world, because that's what really streamlines this process. So because, we don't have enough time, we're only going to look at a couple of these items today. But I believe that, it's important to use literature and research to make good decisions in our practices. And, the challenge of digital dentures is that even though they've been around for, quite a long time with Avident and Palident back in the day, um, the materials that we used really kind of gave them a bad rap, especially in the printed world. Those early materials were horrible. They looked bad. They were super fragile. Um, they really just, it was a means to an end to say I could do a digital denture in the print world, but really wasn't that great. And so, thankfully over time, materials have progressed significantly, but also the research has progressed. A lot of the early research, even from the early 2020s, was still based on old materials, old techniques, old technology. And so, um, thankfully, there's enough research to kind of start to back up what we do in the digital world. And so, I think, the first articles that really hit home for me was this article by the Goodacres, where what it did was it compared a CAD CAM mill denture base to conventional fabrication. So, the pack and press, the pour injection, and of course the milled. And so they measured all these points on these denture bases, and kind of found out that the most accurate was the CAD CAM milled base. And always the gold standard up to this point was the Ivo base injection molding, and we knew that was the best process. We taught it at the academy for our bases, for our relines. It just created the best fitting analog denture. And this article kind of showed that, hey, CAD CAM is even better than that. And so, you know, early on in the print world, which, is only a handful of years ago, there was a variation between printing and milled bases. And, one, the material technology wasn't there, but also, we had this faith and comfort in milled bases. And thankfully, more research, especially this is from 2023, actually compared milled and printed bases. And so measuring a bunch of different spots on the upper and lower ridges of the bases, they were able to confirm that milled and printed are both clinically successful. And in some cases, the printed, was slightly better than the milled. So it makes me start to feel like, hey, I can now offer a digital denture that's either milled or printed based on fit. the next topic that we, have to think about is strength. Are these materials strong enough? And that's where, like I said earlier, I really feel digital dentures got a bad rap because we had this technology, but we didn't have materials that were um, really applicable to be in the mouth. They were able to say we could do it, but just didn't function very well. And not until 2022, 2023, Dentsply's Lucitone material came out, and it really was a game changer in the strength realm. Um, Here's a comparison of five different materials. The bottom two are the same material. One is just at room temperature, and the other one is in body temperature. And you can see that there's a significant difference. The Denka and Prothresia was early resins, very weak. The Ivo base CAD, was very close to the Ivo base injection material. Apex is the sprint ray material, and then the Dentsply material. And you can see that, significantly stronger than even the milled Ivo base. And so it's a material that we use quite frequently. And then the other part of the puzzle is, how do these teeth wear? And it's the materials that we have are always evolving. The Dentsply IPN print material is actually very good at wear. Do all denture teeth wear? Absolutely. Do composite teeth wear a little bit less, than other teeth? Resin teeth? Absolutely. But the wear resistance is quite good in printed denture teeth, and same thing with milled denture teeth. They're both all good materials. So, the strength questions kind of taken out of the mix. The fit questions started, kind of taken out of the mix. So why not now consider these as an option for our patients in doing removable prosthodontics? So, those are two key ingredients in my mind. If it could fit better and it's just as strong or stronger, I now have some product I can use. So we talked a little bit about altering, tooth setups. What happens if we do a try-in and we have the patient close and those back teeth are the only teeth that touch? The bite's open. Did they actually use an articulator in the lab or not? Question mark. But somehow the information we translated to the lab was not accurate, or the information we got back from the lab wasn't accurate. And so, say they had an open bite, or they were too closed, too open. Very easily, we can document what we want to do and send that back to the lab, or we can do it ourselves if we have the software. And you can see very easily we can control, just like we would on our analog articulator, open and close this articulator to manipulate the relationship of the upper and lower jaw. As we mentioned, midline, very easy to move a midline in a denture. We can move every single tooth with a drag of the mouse, so we don't have to reset all these teeth, right? So if we want to just move this left or right, if we just need to rotate it a little bit, very easy to do without having to reset 28 teeth. And same thing with the occlusal plane. If it's a little bit off, those posterior teeth are hanging low. There's something we don't like. We have a little bit of a cant, left to right. Super simple to fix. And say we like our occlusal plane, say we like our tooth position, but the teeth are a little bit too small for the face. Well, we don't need to get another card. The lab's going to charge us for that. We just ask the lab for taller teeth. And so we can make the teeth taller. We can make the teeth wider. We can do it as individual teeth. We can do it as pairs of teeth. We can do it as a whole arch. Super simple to do. And say we want a diastema, we forgot to tell the lab that. Well, very easily we can just manipulate these teeth without having to change our entire setup. So ultimately, if we're in the digital world, we have to take this analog patient in our chair and try to get them on our computer screen. And there's really four ways to do that in removable. So we can intraoral scan our patients, whether they have full teeth, partial teeth, totally edentulous, it all works. We can use their existing dentures. We can make a copy of their existing dentures. or we can make some wax rims. Those are all applicable ways to learn how to take our analog patient and put them into the digital realm. So let's talk about intraoral scanning. If any of you have done, edentulous intraoral scanning, it's a little bit of a challenge. The upper's a little bit easier. The lower, very difficult. Good retractors, dry tissue, um, good scan pattern technique are all ways to really kind of get the data that we need. But it's tough, and I would suggest you try it because, it's a learning experience, and it's something you really believe is the way you want to do digital dentures. It takes a lot of practice. The more teeth we have, as I said, the upper arch is much easier. I love this scan that a dentist did for me. We were doing going to be doing an immediate denture, and look at the extension of the scan. I mean, just absolutely amazing. The palate, look, thinking of anatomy, we have everything we need to be able to make a denture on this patient. The challenge is, where is our peripheral border, right? We know that that's a key component to the seal of our denture. And, one, scan data is kind of like a puzzle, right? It layers piece by piece. And so if that tissue is moving, a lot of times we can't get a very clear scan of that border. And so if I know that information's critical, is that really the best option to digitize my patient and make a denture off of? I would say with immediate dentures, it's a great place to start. For fully edentulous, I think we have a better way, and we'll go through that. But once again, using literature to guide us, Dr. LaRusso from Italy, this is back in 2019, this study basically validated once again that intraoral scanning is an acceptable means to allow us to create a final impression for our denture patients. So my biggest problem with intraoral scanning is, even if I get a good upper impression and I get a great lower impression, how do I control jaw relationship? How do I get my bite scan, right? How do I verify that I'm in centric relation? And then once I even, let's say that we do have a good, jaw relationship, where do my teeth go? How do I know where my incisal edge should be? Is this the right position? Is this the right position? Or is this the right position? I don't know. And I can make good assumptions, especially if I were to make a wax rim, right? Now I can mold this wax rim and really define exactly where my tooth position is. But if I choose to just do edentulous scanning and I want to skip a step, there are some tools to give me a guide. An Alma gauge, I can use the incisive papilla and approximate where my incisal edge would be. Or I can use a papillometer and I can measure lip at rest, I can measure high smile line, and I can start to decide, hey, where should my incisal edge be? So all good guides, but I would rather want to know instead of assuming, based on averages, where teeth should go. And so I'm not a huge fan of just edentulous scanning. I think it's great to make custom trays. I think it's great to, with immediate dentures, to kind of get us to the next phase of taking teeth out and putting an immediate denture in. But as a start for my final impressions for digital dentures, I think there's a better way. And this is my favorite. And so the next couple options that we're going to show, all the key ingredient is, besides giving us a very accurate tissue impression, we also have reference points, right? We can manipulate this patient into centric relation and have a good stop to help us scan that position, right? Because whatever bite we scan, that's the bite, which translates to, that's the jaw relationship in our digital patient, right? If we scan a patient at MI, that's what comes on the computer. If we scan a patient in CR, that's what comes on the computer. If we do a protrusive bite, that's the bite that the relationship of the upper and lower jaw get mounted in. So I have something I can use. I can use a Gothic arch tracer. I can bimanually manipulate. I can equilibrate this denture, all to ways to get myself into the ideal jaw relationship that I'm trying to achieve. And then more importantly, I have a reference point for vertical, and I also have a reference point for tooth position. So all key ingredients that can help me put teeth where I want them. And so, even I can take wash impressions, I can take putty and wash impressions, border molded. I can mark midlines as it show in the middle there where I want to move those teeth. So these copy dentures just give me so much information. And more importantly, I can manipulate them, right? I can't, or I don't want to grind a patient's existing dentures because their borders are overextended. I want, or hey, they have a hidden slide that I want to eliminate. Once I feel we start grinding on a patient's denture, we own it, right? If they don't like the adjustment we did, it becomes our problem. But if I have a copy of their denture, I can do whatever I want to it because it's my denture, right? I'm just using it as a tool to get the information I need. And then very rarely our patients come into our practice with no teeth at all. It's definitely not the norm, but every now and then they do, whether they lost dentures or, over time never had dentures and are finally in a position to get teeth. Um, but this is the same exact concept, right? I can now use a wax rim to give me all of the details that copy denture did, right? I have all the reference points, horizontal and vertical position of my incisal edge. I have my midline. I have my lip at rest, my smile line, my canine position. Um, I have a reference point for vertical. I have a way to record my jaw relationship, all things that have a physical piece of information in my scan that allows me to then start to figure out where the teeth go. One thing you'll notice here, if we think about how we do crown and bridge, we always scan an upper, we scan a lower, and we scan a bite, right? It's all in one order. In the analog world, we take an upper impression, we take a lower impression, we send that to the lab, they give us wax rims, we do what we got to do, we then take a bite, and then we send all that back. It gets mounted. So all these steps that take place, but in the digital world, we can use either our copy denture or our wax rim as our perfect custom tray. We can now get final tissue impressions. We can get our jaw relationship in the right spot. We can take our vertical and have all that information in one scan. So it becomes much easier now to put all the pieces together and get the patient teeth. So this is how we treat a lot of our patients. They come in with failing dentitions, and through the years of all on X and having clear choice, pushing us to do teeth in a day and all those things, we always kind of look at, hey, how can I get these teeth out? How can I get implants in? How can I get these patients in provisionals as quickly as possible? And if you've done it long enough, you also come across failures. And for an extra month or an extra 2 months of healing, I firmly believe that I want to verify tooth position, vertical dimension, jaw relationship, all of those things, aesthetics, phonetics, before I put implants in somebody's jaw. And so, yeah, it takes a little bit longer, but I want to know all those answers. And so, whether we are doing, final treatment as complete dentures, whether we're doing final treatment as all on X or some concept of those combined, my process is I want to get them into immediate dentures. And so here we have this patient, totally failing dentition. I love his smile because, his right side are his upper teeth, his left side are his lower teeth, but it kind of looks like he has a full upper dentition almost, but that's his bite. So we did some scans and you can see the blue, that's his original. And so we kind of looked and figured out, hey, where do we think his incisal edge should be? And we used that front tooth as a reference, and we knew we had to bring it back. We knew we had to move it over a little bit, but we had a guide. We liked his posterior position on one side, so that became our buccal corridor reference, and we kind of matched the other side. And so here's how he presented, and we made immediate dentures, and here he was the day of extractions. And so very easily, by having reference points, we were able to get his teeth in a pretty good position. Lip at rest looks good. He's kind of numb. His smile's a little bit altered, but overall, full smile looks good. Tip down smile. We can maybe bring them out of hair. But in general, occlusal plane, all of those things are pretty close, and we can start to evaluate him as he heals, and so as we look at this setup, number 11 kind of is flared out. Maybe the canines are a little bit long, occlusal plane slightly canted. There's little nuances. Buccal corridor on the left side is kind of not as good as the right side. But this isn't our final denture, right? We always make our patient 2 dentures with immediates. The first one is just that way to get your teeth and give you a smile and give something to start to work with. And then once you heal, we transition to a second denture. And so just like our copy denture, this becomes our copy denture, and we have new reference points to make. And so this guy healed for about 5 months. And then here's his final dentures. And you can see we improved what we had, which we thought was pretty good. But I feel we did a pretty good job on where his teeth ended up. Here was his start. Here was his immediate dentures. And here's his final dentures. So pretty decent result. All because we followed those sound removable prosthodontic principles. And so sometimes in dentistry, we have emergencies, right? We try our best to block schedule and schedule for production and, schedule blue time and all those things. And sometimes we have patients that just don't agree with that concept, or at least I don't. And just like other dentists, this was a dentist that we were doing some lab stuff for. And so this patient had, failing crown and bridge, and the patient came in, broke part of it, and a provisional was made. And eventually she was in provisionals, and with the intent of, hey, I want implants. And she would get her new provisionals, and then she would disappear until something else broke. And finally, it got to a point where, this whole side, there was just nothing left to even hold a provisional in. And so, we had some intraoral scans. And so I went ahead and made a copy denture, kind of a denture over denture, I guess I should say, over her preps. And I didn't have a palate. I didn't have a good, this was just a tooth intraoral scan. And so, which brings me to whenever we scan a patient, just get more data than you need, always get the palate, try to get as much tissue as you can, because you never know what we may need the scans for. But in this case, we were short on the vestibule. We didn't have a palate, but I was able in the software to go ahead and give this patient something. And so our plan was we would take this try-in, feed it over the preps, kind of take our border molded and washing impression. And so now we had a palate, we had a very good defined border, and we would make a overdenture over these preps. And so now the patient can get her teeth out. She would always have teeth to wear, kind of our immediate denture version over preps. Let her heal. We would verify tooth position, and now we can know exactly where we want to put implants. Very difficult to do in the analog world. So in 2 visits, she was able to have a denture that she could get through the extractions on her own time. And then we would use that to plan for implant placement. So here's another case where, like I said, the longer you practice, the more failures you see. And here's a bar where some implants were failing. Same concept, we only had, just scans. We didn't have, palettes and all these things. And so we got as much detail as we can. We designed basically copied this patient's, horseshoe overdenture, and just made so the bite would be the same. Created a palette digitally. We took, wash impressions over that and designed it, and then printed the denture. And so, this fit passively over the bar. There was no pressure on the bar at all. And so now we were able, under our own time, to deal with the failing implants. The patient wanted to get in, do the same type of restoration, but we were going to have a long time, right? We had to have implants out, bar removed, new implants placed, new impressions, new bar, partial, all that stuff fabricated. And so here he is the day of the overdenture going in, the bar still in place, just fit right over it. And we kind of achieved, our objectives, right? And now we can non-emergently treat our patient, but very quickly we can solve problems with removable prosthodontics. And then, of course, we all love All on X, or some of us. And the best way to plan is to know where the teeth go, right? And I love Dr. Turbophil. I took his class a bunch of times. He was just absolutely hilarious, but amazingly knowledgeable on the art of dentistry and the art of removable dentistry. And I love his quote too, kind of like Dr. Dawson's, that, hey, just because we can put implants in, it doesn't, relieve our responsibility of making sure that everything's in the right spot, right? Physiologically, mechanically, functionally, things need to be in the right spot. And so with the invent of dual scans, we can now take our dentures after we verified tooth position, figure out where the implant should go in our planning, and create all different kinds of guides to help us place these implants. And then data stacking, sometimes either we don't get enough information in our intraoral scan, sometimes we just need more information, and this is where immediate dentures are home run digitally, because in the analog world, if we just saw these teeth off, we lose all reference points. Well, digitally, I can stack different scans over the top of each other. And so in this case, we plan some bony reduction. So we're able to, figure out where the bone should go. We can visually see that. We can make a clear surgical guide for the surgeon if we need to, or we can video this. And so the surgeon can have an understanding of, hey, here's how much we had to remove for our prosthetic space. And, make sure you take off enough so we can do what we do in the restorative world. And then in this case, the yellow is our intraoral scan. And I just didn't get enough detail. And so I was able to merge the data together. So now I can get better extension with a traditional impression and still have all my references from my from my intraoral scan, sorry. And then this is a really old digital case, this was pre pandemic. This was a milled denture, but we had a young patient. He, failing dentition, really wanted to get an idea. He just wanted to change his look dramatically. And so we went kind of Joe Hollywood and gave him some big bling and, big wide buccal corridor. But we were able to layer the data so he can really see what we were going to get to before we even started. So he was really concerned about that, and so it worked out well. So let's go ahead and look at a combination case, and combination meaning fixed removable. And so here's a patient of mine. We saw him for a handful of years, and he come in, I want to get stuff done, I want implants, and then he would get one tooth taken out, and then he'd disappear and then come back, kind of the same story over and over. And he finally came in. Number 10 was just bugging him beyond belief, infected. Got that taken out. And so we decided, hey, we need to figure this out. And financially, he still wasn't available to look at upper and lower fixed implant restorations. And so we kind of went through our workflow, right? We did our appropriate treatment planning, just going through our Dawson checklists. And we started to say, okay, hey, what can we do? And, look at those tori, right? Can we do a removable denture down there? I would say no, right? Not without a lot of effort and grief. Looking at his upper arch, super narrow, but he has this really massive ridge. And, ridge height is the key ingredient to, that is the trump in stability of dentures, right? Whether upper or lower, the bigger your ridge, the more stable your denture is going to be. And so my plan was to say, hey, we definitely need an upper denture. As much as he would love something, fixed with implants, not in his budget. But most of these lower teeth, with the exception of those couple decayed teeth, we felt that we were going to be able to restore. And, we kind of had a question mark on one or two of those teeth, but we said, hey, let's clean them out. And no. And so we went through our digital planning. Here's his pre-op, open bite record. And so we designed our lower teeth. And, this is our digital wax up. We kind of went through, we did our virtual extraction. So we had an idea, do we have enough space? We did our setup. And so now we were ready to, hey, let's go to the mouth. So our first visit, we prepped all the teeth. You can see, there was a lot of decay underneath the gum there. So 28, looks a little flayed the day of preparation, but we didn't have to do a whole lot of occlusal reduction because all that was done for us. We just kind of went through, smoothed them out, got a good scan. We print 100% of our provisionals based on our wax up. So there's no more variation, me pushing too hard and having thin areas, changing occlusal plane. If it's an exact copy of our wax up. And the best part is those margins are immaculate. And so the next couple pictures, if you take a look at the gums, this is same day as preparation. So pretty gnarly. As we go through the next couple slides, just take a look at that gum tissue and start to see how well it's healing. And so day one, we prepped all the bottom teeth. I just kind of flattened out these upper teeth. We were going to see, he was going to go see the surgeon the next day to get these teeth out, or a couple days later or something like that. So I just needed to be able to get teeth to touch, so it wasn't just one tooth or one little edge banging into them. And so here he is, the day after, having all his teeth out. Here's our immediate denture. Once again, it's our provisional. But you can see from our plan, we did pretty good, right? So we have a nice level lower occlusal plane. The upper's in a pretty good position. Aesthetically, looks pretty good. His upper midline is where it wants to be. We're kind of at the mercy of where his tooth roots are. So his lower midline just isn't going to be there. But start to look at these tissues, right? Even pretty quickly, after a few days, that tissue's looking pretty healthy. And so, we kind of manage, just like all our immediate dentures, we kind of get them through that process. Some are easier than others. And we finally got to a point where we're like, okay, hey, we're ready to, think about making our final restorations. And so one of the challenges of printed materials is it's more on the resin side, but it's kind of like an acrylic, and not a whole lot of materials, relines, rebases stick to digital dentures, especially the early ones. We're getting a lot better, but it's still probably one of the limitations of printed materials. And so this is a product called, it's by PacDent. Rodin is their print line, soft reline kit. It does stick to, 3D materials, PMMA, and acrylic denture materials. It works pretty well. And so it kind of reminds me of, Voco or Tokuyama soft reline, that kind of silicone reline type material. It is a kind of a polyvinyl family. So if you were to take a wash impression, you won't be able to get that wash impression out without peeling out your reline. So they do bond together. So we use this as our kind of functional reline impression material for most cases. You can see where, these extra pink are, it really did fill in. He had a lot of shrinkage in some of those extraction areas. And so here it is in the mouth. We trimmed it off. Good border extensions. I love this video. Hopefully you guys can hear it. And that's my favorite sound of a denture when it finally releases. You hear that, big old suction sound. So I was really happy with that. Patient had to work hard to get it out. We feel like we're pretty close to being ready to get to a final denture. And so we're going to go through another immediate case here. And, we always, like I said earlier, most of our denture patients, I think in everybody's practice, we kind of like find a little space off to the side of our schedule. Hey, you need teeth, or hey, your teeth are failing, or hey, you want new dentures. Like, sure, let me grab some impressions. We'll see you in a week or 2 weeks. And hey, we'll see you then. We'll do it again. And we don't really spend enough time with our patients. And Just because they don't have teeth or they're losing all their teeth, we still need to give them the benefit of a complete exam. And because sometimes we think cases are going to be easy and they're not, it's like, hey, in the crown and bridge world, you got a old crown that has decay under it. You're like, oh, piece of cake. We're going to cut this off, clean it out. And next thing you know, you're staring at mush, right? We don't know unless we spend enough time to really evaluate and communicate with the patient what we see as challenges, limitations, just so they have some expectations of what we're looking to do. And so, here's our immediate case. And so, same thing, another patient who, long time patient, want us to do treatment, kind of, one tooth extraction at a time, finally got to that stage where, hey, I want to do something. And so, great, we talked about dentures before. Awesome. You need teeth. Let's do it. Right. And the challenge with cases like this is if we don't spend the time up front, all of a sudden we have patients in dentures and we don't know why the patient's struggling. We don't know why they're not fitting well. We don't understand, hey, we just put new teeth in there. Why aren't they working? And now patient expectations are not met. Patient satisfaction's way down. God forbid, word of mouth. Hey, that guy can't do dentures. He's not good, whatever. So let's spend the time and really start to look at our patient and figure things out before we get into a irreversible stage, right? And so, we brought him in, and obviously he's got failing dentition, right? Teeth are mobile, decayed, all those things. But we did an exam, and if we just look at these two pictures, there's something big lurking behind those teeth, right? We can see this enormous tongue, and when I first got in there, kind of didn't really pay attention. I'm looking at teeth like we're trained to do, and we kind of just say, yep, non-restorable, non-restorable, non-restorable. Can't do implants, or hey, maybe we want to do some lower implants, but sure, let's get some scans. But we've learned through experience, hey, let's take our time. And so we'll see in our scans. The other thing we noticed is this guy has almost no palate, right? He's got this little ridge where he has teeth, but on the inside, it's flat as can be. But we did some scans. And, as expected, the upper, okay, we could work with it. We would love more extension on the peripheral, but, you know, we can make it work. The lower, we just could not get enough information. And so we took some analog impressions. We always take photos. So here's our intraoral scans, and you can't really see how flat this palate is, but it's pretty darn flat. There is not a lot of ridge there. He's got some tori on the bottom, not as big as our other guy, but another limitation. Not a lot of saliva. Lots of check marks that tell us that, hey, this isn't going to be a normal denture. And so we communicate that with the patient, right? We let the patient know our concerns, our limitations. It doesn't change what we're going to do, but at least the patient has an understanding that his dentures might not be like his wife's dentures, who has an enormous ridge, or his parents' dentures, or whatever. And so we always want to make sure that we spend the time and we communicate those things to our patients. But most importantly, with immediate dentures, he had enough teeth that once again, we had reference points to start to set our teeth. And so based on our photographs, lip at rest, high smile, profile smile, tip down smile, we can start to say, hey, are his natural teeth, even though they're failing, anywhere in a position that we can use to determine where we want our current or our new teeth to go. And so I liked his number 8. I wanted to move the midline over a little bit. His teeth were a little bit flared, so we knew we were going to bring him back. But we had a good starting point. I liked his buccal corridor, right? Like his 4 and 13 were in a reasonably good spot. And so that was, again, our reference point to start to consider, is this good enough for our buccal corridor? And so we went ahead and set our upper teeth. We did our virtual extractions. We then, brought in the lower teeth. We looked at our occlusal plane, and then we went to immediate dentures. And so here he is the day after extractions, I believe. Teeth went in, and guess what? We did a pretty good job of trying to figure out where his tooth position was. Occlusal plane looks pretty good. His bite looks pretty good. Once again, lurking behind those teeth, you can see that tongue just trying to jump out of there. And so, did some bone work, did some extractions. These are just monoblock printed dentures. We just stained and glazed them where the pink was. And here he is, pre-op and post-op, day after extractions. So pretty drastic change, but the teeth fit, right? They're in the right spot. So we knew going in, this was not an easy patient. And so applying those analog principles, once again, right, whether it's analog or digital, we're going to take our removable principles and now we're going to be critical, right? He's healed. He's been in these immediate dentures for, I believe, about 6 months in his case. And hey, I want to evaluate every step of this process that I did. Things seemed okay. I felt like I got CR, but I wanted to verify, right? I wasn't 100% guaranteed. And so that was check mark one, because I know if I can have my teeth set up in centric relation, they're going to fit better than if they're not in centric relation. My occlusal plane I felt was pretty good. So I felt confident that I was okay there. My tooth position, I liked it aesthetically, but I wanted to figure out, could I improve it? And we'll talk about why in a second. And same thing with vertical, right? He was good. I use vertical dimension of speech or speaking space as my way to determine whether my bite is too open. It doesn't tell us if we're over closed, but it will verify that we're too open. Meaning if I retract the patient's cheek and I have them speak, especially S sounds, if their posterior teeth touch, then their vertical dimension is violated and they're too open. So every denture I do, I will confirm my vertical position that at least I'm not too open by recording and visualizing speech. And aesthetics, same thing. I wish I tried to get him to trim his beard, but for years he had it and wasn't going to happen. And then aesthetics, or sorry, phonetics, he was able to speak pretty well. But like we talked about it in our exam with him, you know, anytime somebody doesn't have back teeth, they're going to chew on their front teeth, right? That's all they got. So it can be challenging for some denture patients, because we know we need them to bite on the back teeth. And so, if they bite on those front teeth, they're going to dislodge the denture. That tongue was massive. It was not in a good position. There's Wright's classification dictates, success of lower dentures where that tongue position is. Is it lay flat? Is it back? Is it, kind of all consumed? In his case, he had a very poor tongue position and it was monstrous. And then also, that flat palate and lingual tori were going to be challenges. And so those are all pieces of the puzzle that we said, hey, I want to go through and analyze and try to get it as best as possible to make sure we had a good outcome. And so the perfect opportunity now is, hey, he's stable, he has teeth, we can now take our time and go through these things. And so in the denture world, Gothic arch tracers, we use Massad's version of that, is like the Lucia jig for dentate patients, right? It's the home run to get your patient into centric relation. And there's other ways to do it. Like I said earlier, we can bimanually manipulate. A lot of times I will equilibrate a copy denture so I can eliminate hidden slides, and just make sure we're in centric that way. But some patients are tough, right? And so sometimes we need posterior flat planes to help us out. So Massad tracers are my go-to because, like I said, just like the Lucia jig and leaf gauge, they're kind of easy to do. So we were going to verify that. Tooth position. So, with his tongue, we talk about airway in today's dentistry. If I could bring his front teeth a little bit more forward, that would give us a little more volume, a little more room. And then also, those posterior teeth, on the bottom, he was set up kind of in that perfect overbite overjet relationship. I felt he was definitely a case, based on where the ridge was, as well as trying to create more tongue space. I needed to bring those lower teeth out and therefore into crossbite. And I had plenty of speaking space. So I wanted to, once again, open his vertical a little bit more, just trying to create some oral volume for that massive tongue. And functionally, when we just did analog, HydraCast was our functional impression material. We did it on every denture. It was the home run to making predictable, well-fitting dentures. We taught it in every Dawson denture class. Just an amazing material. Well, they don't make it anymore. There's a new material called Flowcast, but once again, it doesn't stick very well to printed dentures. And so, thankfully, most digital dentures fit so well, we no longer have to do a functional impression to get us to that home run state. But in this patient's case, I needed everything in my tool belt to try to give him the best result. So I was going to go ahead and do a functional reline impression, work on retraining. And we always talked about through this whole process that, hey, maybe we need a couple implants to help us with an overdenture type appliance. So here's our massage tracers. So we basically have an upper platform, a lower pin, and we have the patient slide forward backwards, left backwards, right backwards, and it creates this arrowhead position. We then take a 6 round burr and just make a little divot right at that point, and that is centric relation. How simple is that, right? It's like our Lucia jig. We put articulating paper on there, they slide forward, backwards, forward, backwards. That most back position is centric relation. It's a home run. So the other great part about massage tracers is if you're trying to take a centric relation bite record with upper and lower wax rims and you're guiding your patient in, what happens to that base? There's a lot of saliva. If it's not well fitting, it's moving around a little bit. Like, are you really in the right spot? We don't know. With a massage tracer, with Gothic arch tracers, because that pin is creating vertical force, it's seating these denture bases, right? Whether it's a wax rim base, whether it's a copy denture base, whether it's a final denture base, it helps to seat the base so it's as stable as it can be while I'm recording centric relation. And so it's just the home run. So we inject some blue mousse. I liked, if you look closely, these are mounted on esthetic trays because I try to do the least amount of work chair side I can do. If I can do it in the lab that I want to do it. So I will just snap these on to whatever it is, and then I don't have to glue these pieces together chair side. And so we then inject some blue mousse so I can verify that. Or I can scan this without the blue mousse right there in that pin. If I was doing this as a copy denture, I would just have them seat in that position and scan my buccal bites. And now I have my jaw relationship scan. Once again, this is an open bite record, but just like we do with our dentate patients, we just close that pin down until we get to where we want it vertical. So one last point I want to pick out is take a look at his size of the width of his upper arch to his lower arch. Hugely different, right? Obviously, this is a crossbite case. So even not just doing it for tongue space, we need to get these teeth over the ridge. So enormous difference in the size of his arches widthwise. And here's our HydraCast, technically Flowcast. We went ahead and did it. We want this nice white border around the edge. We had a little bit peel back on the lower when he came back in to do scans, so we just touched that up before we scanned it. We just scan this now. We used to have to box it, pour it, and then send it to the lab. Now we just digitally take care of that. But this material is almost as great as HydraCast, and it really still is the best way to get the best fitting denture possible. And here he is, his final dentures, beginning. This is his immediates. And he didn't trim it, but he did let me part them so we can get a little bit better teeth position. So he was nice enough to let me do that. And then here's his speech. And so as we play this, besides listening to him speak, look at how these teeth are, look how stable they are. He has no ridge, top and bottom, but because we've done this digitally, those dentures are extremely stable. And so we've really helped him through following all these, removable prosthodontic principles to give him the best denture that I feel we could do based on his situation, right? Every patient's different. So as we go to finish up, where does digital fit in your workflow? This is how we used to do it, right? This is the totally analog way, upper and lower impressions, final impressions, wax rims, wax try-ins, and final dentures. that way still works, right? There's nothing wrong with still doing what we do. But hopefully, I've stimulated some interest into the digital realm, especially with dentures. And so the cool part is we don't have to be all in, right? We can take little pieces of this and start to learn it, start to incorporate it. So whether we take traditional impressions and we scan them, or whether we take traditional impressions, pour up our models, and then scan that and digitize our patient, whether we take intraoral impressions, whether we, or intraoral scans, sorry, whether we take impressions and scans of our wax rim or copy dentures, these are all ways to digitize our patient. And there's no wrong way in this process. When it comes to try-ins, right, do we use wax rims to verify tooth position? Do we use denture teeth and set up it analog ways? Or do we look at some type of digital process? And so this is the same exact base or try-in, both are monoblocks, the same exact ones, both printed. One, we just stain the gum tissue. The other one is that skeleton look. So one thing I didn't talk about is our try-ins now, the patient goes home with them, right? This is a solid block of denture material. So it's strong, wear resistant. This becomes our patient's backup denture. But more importantly, if we try this in, even if it has all his teeth, the patient can't go home with it, right? That wax is going to melt, they're going to fall out. But now the patient can go home, they can verify aesthetics, phonetics, vertical, occlusion, all of those things, and we can make changes, right? This is not our final denture, but more importantly, they can make sure that not only do they like them, but their spouse likes them, their siblings like them, their kids like them, whatever it is, they have something that they can eat with, chew with, and wear as long as they want, really, to verify that everything is good as it is. I want to make sure that at this stage, there's no compromise to fit. There's no compromise to aesthetics. There's no compromise, at least in tooth position, kind of like our provisionals in the dentate world, that everything is complete and acceptable. If we have minor changes, I don't need to do another try-in. But if something was really off, if I had to do a lot of adjusting, I'm going to do a second try-in. But because we really utilize reference position, the amount of try-ins we now do in the digital world is so much less. I would say almost always we're doing one, very rarely a second try-in, because we really have fine-tuned the ability to use these points to guide us, that back in the edentulous world, we had this big vast space. And lastly, how do we process it, right? Do we still use injection molding and, maybe some custom staining, right? This analog denture on the left, or do we mill them? Do we mill the bases? Do we mill teeth? Or do we consider printing now? Here it is, printing bases and printing teeth, and we glue those together, right? So all ways to digitize things. And so I want to thank you for your time. I guess it's just under an hour. Hopefully you're, stimulated about digital dentures. Hopefully you can see that I'm excited about this topic. We'd love to spend more time uh, going over it. We have a great denture course at the Dawson Academy. Any questions, please let me know.